use a fixed dose DPP-4 with a metformin combination, which is the commonest combination used, then your HbA1c values become more compliant, and the HbA1c values become more towards the norm. This is a relation between HbA1c and the proportion of patients receiving a fixed dose DPP-4 inhibitor. So higher the patients are receiving a fixed dose combination, the lower your HbA1c. So this maximizes adherence. Once a day is the maximum adherence compared to 3 times a day. Adherence with once daily versus 2 or 3 times daily, adherence is much more than 2 or 3 times a day. So compliance and adherence to treatment, particularly for long-term treatment, we need these sort of long-acting and combination drugs which have very little side effects and can help patient achieve the target with minimal problems. What are the potential advantages of early combination? More rapid achievement of targets, use of lower dose of individual drugs, so less side effects, opportunity to combine oral antihyperglycemic agents with complementary modes of action, so that you can get 1 plus 1 is not always 2, it might be 3 or even 4. So what do the guidelines say? These are the current guidelines which come out in April 2012. They have different charts like this. This chart which I have taken out is healthy eating, weight control and increased physical activity. Metformin is a drug of choice. And in the second line, they put drugs like sulfonylurea, azoxystrobin, DPP-4, GLP-1 receptor agonist. Unfortunately, the alpha-glucuronidase has not been put here, but in India, for us, it is one of the second drugs of choice. And of course, basal insulin. If you want to use weight control, then you have to use DPP-4 inhibitors and GLP-1. These are the weight, this is neutral and this is weight-reducing drug. So for weight control, these are the drugs. Remember, azoxystrobin will make you put on weight. So what are the other considerations? When you want to put a patient on an agent, oral or insulin, what are the other things? You have to look at the comorbid conditions. So if you have coronary artery disease, metformin has been, one of the drugs is metformin has been shown to have cardiovascular benefit. That is in UKPDS, where they looked at newly diagnosed type 2 diabetes. And I called, remember, we had patients who had diabetes for 8-10 years with complications, whereas in UKPDS, they are newly diagnosed type 2 diabetes. So they have cardiovascular benefit. This avoided hypoglycemia. Okay? Then this UKPDS gave us problems with the sulfonylurea might cause problems with preconditioning. Pioglitazone reduced cardiovascular events, but at the expense of weight gain and fluid retention and heart failure. Okay? And therefore, and then we recently had these incretin-based therapies. This is for the coronary disease. For heart failure, metformin may be used, but you have to be very careful. You should avoid PZDs. Incretin-based therapies can be used in these patients. Of course, insulin can be used, but they can cause hypoglycemia. Liver dysfunction, most drugs are not tested in advanced disease. Insulin will be a drug of choice, small doses of insulin. Pioglitazone may help steatosis, but if you have fluid retention, you have to be careful. Insulin is the best option, particularly for severe disease like established cirrhosis. Hypoglycemia, emerging concerns regarding association with increased mortality, and we need to have proper drug selection to avoid hypoglycemia in prone patients. Who are the ones who are going to get hypoglycemia? The elderly patients or the very young patients with renal failure, with hepatic failure. These are the patients who are most prone to get hypoglycemia. So these are the patients where you have to choose these specific drugs. So we just finished my talk with this combination which is now currently available. We've been using saxagliptin for a long time now, and this combination, metformin, sustained release, fixed dose combination. The difference between this combination and the other DPP-4 metformin combination is that this is extended release combination. All the others, sitagliptin, vildagliptin, which are available in combination, are instant release combination, and they therefore cause more GI side effects compared to the fixed dose combination. And I'm sure you've seen this slide before about the incretin, and that's food in which is extract, and it works at different places, including glucagon, liver, and other places. If you use combination of metformin with saxagliptin, you get complementary action. The highest reduction, remember, with any DPP-4 inhibitors is a combination metformin. What is the reason? You need a lower dose of your DPP-4, and metformin itself raises your GLP-1 levels. So the GLP-1 levels are raised by metformin. So a combination in all studies for all DPP-4 have shown the highest reduction in your A1C compared to others. This is about saxagliptin. I won't talk very much about that. You know, I'll just mention a little bit about metformin. This is the only agent recommended by AD and ASD as first step 1. Okay, most commonly combined with other glucose-lowering drugs and commonly available as immediate and extended release. I do not use any immediate release metformin because majority of the patients cannot tolerate. Okay, we will look at these reasons. That's your mechanism of action. Metformin is mainly reduces the hepatic glucose output, reduces GI absorption of glucose, and increases insulin sensitivity in the peripheral tissues. In metformin, what happens? The dual hydrophilic polymer matrix XR allows once a day administration. And market research has shown, including myself, that physicians prefer metformin XR because it's once daily dosing and most commonly prescribed because immediate metformin causes a lot of side effects. What is the rationale? You have metformin, the usual dose is twice a day, you produce gastric irritation, non-compliance. If you give metformin XR, you have less gastric irritation, more compliance. And what is the rationale combining these two drugs? As you mentioned, metformin is the gold standard. DPP-4, as per ASD, is your first add-on in type 2 diabetes. Complementary mode of action, ideal combination. Disadvantage of metformin is gastric side effects is reduced compared to instant release. Metformin XR, as you can see, very less side effects once a day. And saxagliptin produces minimal hyperglycemia and weight neutral. So this profile is excellent as far as the patient is concerned. So this is the, as we mentioned, this is the biggest problem with immediate release. 90% of the drug is dumped in your GI system within 30 minutes, whereas this is released over a period of 10 hours. So that is the main reason your side effect profile is better. So the side effect profile of metformin instant release, okay, and XR, you can see that the prolonged release metformin, the side effect profile is much less, whereas instant release side effect, and all the parameters, diarrhea, vomiting, abdominal pain, is much higher compared to the side effect profile of immediate and XR. Even if once you switch that someone from immediate release to extended release, what happens? That the side effect profile for switching, you find that when they are on the immediate release, they are high side effects. When they are on the prolonged release, the side effect profile for the same patient becomes much less. And this is the profile for extended release once a day. So that is why you get a long duration action, whereas in instant release, peaks and troughs. So once a day XR given is equivalent to a high release given in divided dose. At least 500 once a day is equal to 2 tablets of immediate release. And this is being shown in some of the studies. This is bioequivalence of this saxagliptin metformin fixed dose and single component saxagliptin and metformin XR. We give it separately and give it in one combination. So this study was done in patients, and the glycemic control at 12 weeks was seen. And you can see that with XR, the side effect profile was much less, both with the 1000 and the 1500 milligrams compared to the twice a day instant release. This is a little diagrammatic form of how saxagliptin and the glucose control. So what does it do? These two, if you use a combination, targets 3 main drugs. It increases insulin sensitivity, increases insulin synthesis and release, so works in a glucose-dependent manner and decreases hepatic glucose. So they have a complementary mode of action, as mentioned. And it is again once a day because you're using sustained release. Anyway, saxagliptin has a very long half-life, which works for 24 hours. Okay, with this, I'll just pause because I'll pass on these technical details to Dr. M K Mukhopadhyay, who is a medical advisor of BMS. He'll take you to the technical details of how this molecule has been. It took a long amount of research to develop this extended release metformin along with saxagliptin. And then I have a few slides at the back and I'll come back to them. Thank you very much for the time.